This is Healthcare Now Radio's Trending Now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
Welcome to Trending Now on Healthcare Now Radio, where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Today, we're really excited to have a fellow Healthcare Now radio host, Frank Cutitta. What's trending now and what Frank and I will discuss is a wide-ranging set of topics because his background and his experience is magnificent, and there's a lot that we can learn from him. But really, we've all gone to recent conferences, especially like Vive and HIMSS and a bunch of other events. Frank's done a lot of work with CHIME, which, of course, as most of you know, is the organization which supports, it's an association that supports chief information officers at healthcare organizations. So we're going to use all of that knowledge from Frank to talk about what he's seeing happening today and what things are worth buying and investing and investigating more versus those things that might not be. But before we jump in, Frank, tell us a little bit about yourself.
Well, I have sort of a checkered background, so I could go a lot of different directions. My main work right now is with CHIME as the senior strategist there, working on building their media and their data business called Digital Health Insights. So I've been there for the better part of 7 months now. And I'm a university professor, University of New England, Northeastern University, where I teach in the health informatics department. And I've got a checkered career going back to HIMSS, where I was on the global board there. And also built media companies around the world for a company called IDG, better known as Computer World, PC World, Info World, and the Dummies book. So I came into healthcare probably 10 years ago after being in technology in general. So that's my background and what I'm doing right now. Appreciate you having me on the show.
Sure. And one of the things that excited me about this conversation is your significant expertise and experience outside of healthcare. So there's a lot that we can apply. And I mean, healthcare has a lot to teach other industries in terms of empathy and how to care about people. But healthcare can also learn a lot. And so maybe let's just start there is one of the things that I noticed that Vive and HIMSS over the last couple of months is that there are a significantly higher number of quote, non-traditional healthcare vendors and healthcare innovations coming in from into our industry here. So having attended these major healthcare IT events over the last few months, what are some of the top technologies that you think buyers should be prioritizing versus where is the hype coming from and maybe people shouldn't be spending too much time on those?
Well, I mean, unfortunately, the hype is where some of the real interest and opportunity is. So, obviously you can't go anywhere without hitting AI in some way, shape, or form. And so that's almost like talking about oxygen right now. But you've got to narrow it down about what part of AI. There's one of the things when you're talking about hype is there's this thing right now called AI washing. Just sort of like we had greenwashing during the sustainability days. So AI washing means that anything, whether you have it or not, has to have some kind of copy in the brochure or on the website about AI. The challenge is coming up with proof points. So that's one of the areas where there's tremendous opportunity. But I work in a world of what I call hyphenated AI. So how many hyphens can you add onto AI to make it meaningful as something specific and to use a medical term, more surgical, as opposed to just AI. And there are a lot of things like that. Cybersecurity gets into the same area. But if you want to get more specific about where I'm seeing things that are real and are dodging the hype curve, I did analysis after Vive of what the most commented on topics were. And one of the ones that's hot right now is hospital at home. That whole movement is exploding, value-based care in the home, high acuity care in the home, as opposed to just having home care. Two totally different things. It's hospital grade care in the home, which is really doing very, very well right now. And the interesting thing about that, when you listen to and go to some of these sessions, whether it's at HIMSS or at Vive, and I did the first hospital at home conference myself, build the blueprint for that. These have massive effects on infrastructure, connectivity, mobile monitoring, and just logistics in general, getting all these people going into homes, which might be multi-generational in low-income sections. So that's a really big area right now, which encompasses many, many of the technologies that we're seeing.
No, I love that because we also at the same Vive conference we did, or maybe it was at HIMSS, where we did interview John Halamka, who runs a full medical home platform at Mayo Clinic, and he was basically saying the same thing: is that they've learned that there's a lot more possible with hospital at home than we were all thinking. So it sounds like you're agreeing with that at a minimum, if not extending it further to say, hey, when you're looking at these technologies that are super advanced, remote patient care, remote diagnostics, AI, why not apply it to an area that actually has a growth part as well? And so have you seen, Frank, that those organizations that are pushing the boundaries on hospital home can also get their finances in better shape?
Well, there's the loop that you have to look at, and it's good to see that John Halamka, the god that he is in the community, is supporting this. They can get their finances in place by doing this because they're decreasing expenses in some way. The one key challenge right now for hospital at home, and it'll be resolved before the end of the year, is reimbursement. So it follows the same pattern that we saw for telemedicine, that we had the largesse of telemedicine because we had to have it during the pandemic. I mean, there's no other way to deliver care. So the government said we just have to come up with a reimbursement program where this is covered. I think hospital at home has the emotional attachment to it because CFOs like it because of cost. Some of them don't like it, to tell you the truth, because they just built a wing on the hospital and they say, now I built a wing on the hospital, I'm going to be sending all these people home for their care. So there's some controversy in that area, but for the most part, everybody's in violent agreement about the outcomes, the readmissions, the decline in readmissions. All of those things are documented through studies that have been done at the Brigham by David Levine and some of the authorities in those areas. So I think that there is a way of getting some of the money that was lost back during the pandemic back in the hospital at home model, as long as there's one thing, the obvious, reimbursement.
Yeah, that makes a lot of sense. And bringing back, I don't want to bring back painful memories for you, but you're almost legendary in patient advocacy. You also have had your own issues during the pandemic. You were, famously in the hospital for about 100 days or so. Talk to us a little bit about that and say, what would that have looked like in an institution that was properly pulling off hospital at home?
Yeah, glad you brought it up because for me, it was the best of times and the worst of times. So it was the worst of times because I was in a coma for 45 days and had to learn to walk again. But from a researcher's point of view and an editorial guy's point of view, this was a fantastic primary research opportunity for me. So people think I'm crazy. They said, you almost died twice, but you thought this was a great experience. So yeah, I mean, during that time, I wouldn't have been able to avail myself to hospital at home just because of the nature of the isolation situation. But I could see that there were many times with things that were like my own ailment that could have brought people home to be cared for or not brought to the hospital if the environment was right. So the thing about hospital at home, the high bar is in the admissions, where you have to be in terms of all these other factors, the proverbial social determinants of health, for example, where you have to be with all of these things in order to qualify to be admitted at home, so to speak, as opposed to admitted at the hospital. One anecdote: when I came out of the coma, I wasn't able to eat or to drink. It was all tube feeding, and my mouth was so dry. I said it was like Gandhi's sandal. That's how dry it was. So I was begging. I was begging for some kind of ice chips or something like that, and they refused to give me ice chips. This is the other part of technology and communications in hospitals. So finally, one of the doctors came in and said, "I am prescribing that you can have somebody would give you ice chips, but there have to be two people there when you take them, just in case you aspirate." That's perfectly fine. Next day, can I get an ice chip? Everybody said no. I said, I know that they prescribed this for me. It's in my record. The problem was, is the person who prescribed it put it in such an eloquent way at the bottom of the record that nobody would read it. It was just like, there's too many words. There's too many words here. If they just put in all capital letters, give them a freaking ice chip, that I would have had ice chips. But everybody has to be Shakespearean in terms of the way they enter stuff into records. I wrote an article about this, in fact, and so nobody reads it. So I think that there were times during my care, once that I was free to be around people, that I could have probably easily be cared for at home and gotten out of the environment, which is, like we all know, is the most risky, ironically, in the provider in the hospital itself. So yeah, and I think that there's the gradation of when you could release someone to avail themselves to the services that are available coming into your home, 2 or 3 visits a week, and hospital level care at the home. So yeah, that point of cutting the umbilical cord. The other part of it is, we've all gone through this with ourselves or with family members. There's a certain number of patients that just say, I don't want to go home. When I see those cables being removed and the support system changing to people coming in a group car, they all travel together now. I don't really want that, and their family members might not want that. I just can't support that. So there are just so many variables that say, yes, this person would like to go home, but the infrastructure and the social determinants are such that they can't do it.
Yeah, and that's a super important point. Yeah, a lot of other work you've done in your past is around this idea of empathetic technologies and artificial emotional intelligence. How does that weave into, and obviously hospital home is one exemplar. It's a set of examples that we're using, but it applies to most other tech that we're doing. So maybe talk a little bit about what that soft side of technology could be looking like in the coming days.
Yeah, and this is where we look at the hype and the reality of artificial intelligence as we look at voice-enabled devices just sitting at home. And I won't say what the name of the device is because it'll go off right now and start asking me questions. It starts with an A and ends with an ELXA. The thing is that where some of the hype is, especially in the chatbot area, driven by artificial intelligence, is the sentient nature of it is not quite there yet. It's not even half baked. Some of it's not even really in the oven. And part of what happens is that instead of having satisfying experience with artificial intelligence and artificially emotional intelligence, it becomes more of a frustration. A case in point, I was going through during the worst of times with COVID, and I wasn't alone. I was going through 22 hours a day, mostly being alone, except for physical therapy. So I was going through clinical loneliness. So the question would be, is there a form of technology that would have kept me from being increasingly lonely? That when I started talking to him, it would go through a series of branches like most of the chatbot technology does. And then most of that I've seen, even the really good stuff, starts to fall apart when it gets more complicated and as it gets more emotional. So how can you build this emotion into algorithms when emotion has so many different factors? It could be cultural. I'm a Sicilian, so my Sicilian emotion is different than my wife's Irish emotion. So maybe sometimes it's the same. So those are the kinds of things when you look at the diversity of the audiences that you have in the care setting and the diversity of the caregivers, even when you're using scripting technology, like ambient technologies, how that translates into real life, or where can the vendor say, look, this is as far as we can go, and now you have to talk to a human. But the problem is that most of them don't want to get to the point where you talk to the human too soon, because then it wouldn't be a technology that would be worth using.
That is that's such an important point, is if you can get to a vendor that is willing to tell you the truth, that may be half the battle, right? So it's really interesting is that, so a lot of the things you just taught us about the emotional side, et cetera, you felt that yourself. And we'll talk about that in a second. Let me just, if you're tuning in, you're listening to Healthcare Now Radio. This is Trending Now. I'm Shahid Shah, as usual. And I'm talking to Frank Cutitta today. We've been discussing a wide range of topics, all the way from what is hospital at home and what Frank saw at Vive, and where we're learning about the emotional side of things. But if you like what you hear with us here today, Frank, of course, also is a radio host on Healthcare Now Radio. He runs Health Stealth Radio weekdays at 7, 3, and 11 Eastern. And he gives a lot of insights from the shadows of enterprise and patient cybersecurity. And I want to shift a little bit to that conversation now, Frank, is that you just started working with CHIME. CHIME is, of course, a association that helps chief information officers. Looking ahead, where are the key areas that CHIME is focusing on for the remainder of 2024? And you could tie it to the stuff that you've already talked about in the first 15 or so minutes. But if there's new things that you guys are looking at from the CHIME perspective and the insights that you're gaining from that, I'd love to share that with the audience.
Yeah, CHIME is looking at most of the major pillars: remote care, remote monitoring, cybersecurity, artificial intelligence, obviously, workforce, which is enormous, as you can imagine, the challenges that are going on there. But what I'm doing in the group that I'm running in news organizations, we're looking for as many intersections of these things as we can. So what is the relationship between AI and cybersecurity? And the other thing that's coming up that we're going to look very, very closely at is the governance has become very cool again. It used to be your eyes would glaze over, so I was going to talk about governance. It's like having a life insurance salesman coming in. But now, I mean, when you look at the co-evolution of cybersecurity governance and artificial intelligence governance, I mean, they're real factors within the organization, because there are so many different constituents that have to be served that have very strong opinions about it one way or the other. So we want to make sure that we look at how governance is being handled separately in each of those pillars, and how it's being combined together with artificial intelligence cybersecurity governance. Those are the kinds of things we like to look at as integrated cross-functional issues that are critically important right now.
So as you think about helping innovators that are coming in, whether they're innovators at hospital provider organizations, or they're innovators on the payer side, or everyday vendors, the Microsofts and the Amazons, et cetera, of the world, lots of people are having different ideas about how to prepare content and how to convey and communicate and message with their own technologies and innovations. What are some of, especially, I love the fact that you've been in the industry for so long. What's changing in terms of how you should communicate your content associated with your innovations and technology? What could you teach us about what not to do, maybe? Or where are some areas that you're seeing people succeeding that maybe they should double down on and go further, faster on?
Well, one of the banes of the existence of the marketer is that they like commercialized content. They like brochureware and things like that. So one of the things that I've seen for years, and this is no revolution, it's nothing brilliant, but yeah, there's this need to sort of drag people into thought leadership content, not at the expense of commercial content, but to the complement of it. So our work is always trying to say you not only need thought leadership content, but it has to be edgy and it has to have a personality, because what most companies and innovators don't realize is the signal to noise ratio out there is crazy. They don't see all the mail that other people send. They see the mail that they send, and maybe they follow some blogs and some other things and some other mailing lists. But the world doesn't need another cloud computing piece of content of explaining hybrid shared community cloud. I mean, it needs to have some kind of personality and some kind of sizzle that makes it a little bit different. It also needs to have you stand out in the crowd as a thought leader, as opposed to just being another inventor. And I mean that with all due respect. But you see that when John Halamka talks, as you mentioned, people listen. I mean, there's an epitome of the influencer and a thought leader. So that's one of our challenges right now is to get people to come up with something, as Monty Python would say, that's a little bit different in terms of the way that they're communicating their product or their invention.
Yeah, that's such good advice. And so the way I normally look at this, Frank, is that sometimes it's okay to assume that the audience knows that you're trying to sell them something. I mean, sometimes you can just play on that, right? It's not to say that
Right.
you're trying to fool people that they don't know that you're trying to sell them something. The question is, are you trying to sell them something that they need at that time for a specific purpose, etc.? And so I like what you said about the edgy part and personality. Do you have some good examples? You know, you used John as a good example. Who are some others that might be maybe at their Chime, maybe they're at HIMSS and some of the other areas? Who are these thought leaders that you think are edgy that we should be looking at, maybe following?
Well, I follow a lot that are out there that are usually the contrarians. I could post on your site a list of the ones that I like to watch, but yeah, there's no surplus of contrarianism out there. So I do a thing that when I bring some of these people together, we talk about fireside chats, very popular. I like to bring together fireside spats, which I think is really the way to go, because knowledge is gathered by these thought leaders based on, just like the Sunday morning talk shows, it's based on an argumentative society that we're in. So you know, when you look at how you get people together to release knowledge based on disagreeing with each other, is artificial intelligence going to replace 60% of the doctors by 2092? You know, that you could get plenty of people to argue about things like that. Should we pay ransom or should we not pay ransom? We could get plenty of people to argue about that, and half of them won't be telling the truth because they probably did pay ransom, but they don't want the world to know about it. So I think those are the kinds of discussions that I like to have with people, and I like to put them together where I know that there's going to be a certain degree of controversy, so that we could see both sides of the issue. And you know, healthcare is one of those areas where there are both sides of the issue. We're in a business where, this goes back to your question. I'm rambling a little bit. This goes back to your question about innovation in general in healthcare. One of the things I talk about and I lecture about is that innovation is difficult in a do no harm business by the nature of innovation. So healthcare magnifies that because the do no harm could be life and death. In the radio and television industry, do no harm is totally different. You know, what are we going to do? They're going to change the channel, right? So I think one of the things that we try to work on is to look at the risk reward structure within organizations as it relates to innovation, and it relates to the thought leaders in those. And I like to talk to the people who encourage their teams to take risks, number one, and that reward them, number two, for doing it, and number three, of saying, we're not going to keep you here if you don't try to. So I think that's integral into the culture and the people that I like to talk to and listen to.
No, I love those. So the key things you taught us here is number one is edgy. I think that's most people would agree with that. Personality driven, generally people agree with that. The contrarian part is really where I get people to push back on and say, well, we don't want to start disagreeing with our customers. And like, if you don't disagree with them, they're not going to listen to you, right? You have to start to have the conversation there. And I love the idea of the fireside spats, right? We all do the fireside chats fairly regularly. But I think as we look at this, you know, even in our radio shows, what we try to do is get someone to disagree with someone else, because that's where knowledge truly emerges. If everybody's disagreeing, nothing actually is happening. And I love the example you gave that we don't need the 1002nd cloud computing article explaining cloud computing. We often in quotes thought leadership, we assume everyone else is dumber than us, and therefore they need to be explained these things that are the obvious things. But if we just said that they know at least as much as us, but in different subject areas, and our job is to bring them up on our subject areas through a contrarian, a highly thoughtful perspective. That's where thought leadership, I think, has been lacking. And I'd love to get your thoughts on the idea of thought leadership. Where do you think people should be focusing, especially with getting the attention of chief information officers, chief medical officers, et cetera? What are some areas that you think people are not covering enough that we should get some attention on?
Well, it sort of goes back to almost every focus group I've ever done, talking about what customers like least about healthcare vendors. So thought leadership is important to get you in the front door, whether they read it before you get there or when you're talking to them or presenting to them. The thing that most of the customers that I speak with in the focus groups we do at Chime and the ones that I've done independently is that you don't know anything about my system and about my work. You've not, in a world where finding research is literally at your fingertips in seconds, nobody's done enough advanced work to come into these calls and explain how they could solve one of their problems without having to ask the question, which gives us all the creepy feeling of what keeps you up at night, the constant what keeps you up at night question that we ask our customers. And they say, if you haven't researched what's keeping me up at night on your own, I'm not quite sure I could depend on you to have a valid product for any length in time, because are you going to have to keep on asking me when we deploy the product what's keeping me up now that I have it? No, you should know those kinds of things. So that's the first step of thought leadership, is that it doesn't mean that you go out there and you espouse as the great authority on something. That the thought leadership is that I thought enough about you before I came in here to learn everything possible to have an intelligent conversation and start what would normally be 2 hours into what the what keeps you up at night conversation would be.
That's perfect. And in fact, as we wind down, just in the last few seconds that we have, this idea that thought leadership really is you thinking about the customer, not about you and your position or your position in the industry, I should say. That seems like really, really good advice. And it does trouble me that how many sales teams and thought leaders don't just read the annual report from the hospital or wherever they're going to go. So if you just read the annual report from last year, you'll find out what their next few problems are. So with that, Frank, this was awesome. I love this conversation. Hopefully we'll do it again. Just in the last few seconds that we have, tell us where people can find you online and what you talk about in your radio show.
Yeah, well, I'm at Chimes, and the URL is chimecentral.org, and we have another organization subgroup in there that's Digital Health Insights. So DHINSIGHTS.org as well. So those are my two contact points, and I'm easy to find on LinkedIn and other social media sites.
Excellent. Thank you so much. And for everybody else, we'll see you on the next episode of Trending Now on Healthcare Now Radio. I'm your host, Shahid Shah. Thank you so much.
Thank you.